Good morning, everybody. Welcome to Grand Rounds. Happy Tuesday morning. It's my honor to introduce our esteemed speaker this morning, Dr. Stephen Kernie. Dr. Kernie is a professor of pediatrics at Columbia University College of Physicians and Surgeons, where he is the chief of the Division of Pediatric Critical Care Medicine and has been the chief since 2011. He completed medical school at the University of Washington in Seattle, and then did his pediatric residency and his fellowship in critical care in Dallas at Children's Medical Center, UT Southwestern, where he and I overlapped a little bit as I was doing my fellowship in endocrine. He's been highly successful in extramural research funding in very proliferative and textbook chapter writing and numerous manuscripts in the area of brain self-repair after injury, and that is what he is speaking on this morning. So please welcome Dr. Kernie.
Thanks, Micah. I appreciate the invitation here. I was here about 8 or 9 years ago, and the way the place has changed has just been truly remarkable. And it's really been fun for me over the last day and a half to kind of see the evolution. What I want to talk about today is, so I was a fellow, as Micah mentioned, in critical care 20 years ago. And what I want to talk about today is how kind of my views of critical illness, particularly critical brain illness, have evolved over that time based on what we've seen clinically and what we've seen in the lab. So I'm gonna switch back and forth a little bit, and I'm just gonna ask you to bear with me. But it really kind of tells the underlying story of what I think we're trying to do in medicine with some of these most challenging patients. So first of all, I just want to start off with a case. This was a little girl who I didn't directly take care of, but was peripherally involved with when I was in Dallas. She was a 2.5-year-old with a history of a head-on collision at highway speed. She was restrained in the back car seat, but her mother died at the scene. She had a Glasgow Coma score of 4 on a 3 to 15 scale, and a lot of you may not be used to using that score since medical school or something, but you can be dead and have a 3. So she was very close to that. She was intubated, she was flown to a level 1 trauma center, and she had a head CT that showed multiple skull fractures, poor gray-white differentiation, and evolving edema. She had an intracranial pressure monitor placed only because her GCS wasn't 3. Because this is the kind of story that when you hear this story, it's all bad. The only thing she had going for her is that she was restrained. But head-on collision, highway speed, death at the scene, intubated at the scene, obtunded, and she had that going for her, and she was immediately taken to a level 1 trauma center. So those are the only 2 things that suggested there might be some potential for recovery. So the neurosurgeons ultimately decided to go ahead and place an ICP monitor because she got 1 point on her motor score. And the way the GCS is divided, any score on the motor component is kind of the most predictive of having a reasonable outcome. So in her hospital course, she remained unresponsive in a coma. She developed moderate intracranial hypertension, which was treated. She had a CT scan that was repeated. It looked bad. She had an MRI. It looked bad. So there was a big conference with critical care, neurosurgery, neurology, palliative care. And everybody got together and said, she's going to have an extremely poor outcome if she survives. And so the father, who, remember, had just lost his wife, and the grandmother, who was now kind of overwhelmed with doing this, were counseled that if she was going to survive, she'd be vegetated. And so they made what was a very reasonable decision, which was to withdraw support. And they did that, and she could breathe on her own. She could protect her airway. So she was sent home comatose on tube feeds, anticonvulsants, and methadone. So there were a number of things with this case, namely in the last part here, that I think probably could have been handled better. But this part here, when there's a conference with all of the experts kind of trying to predict the outcome, and so it brings up the question, how good are we as medical professionals in doing that with families? So this was published about a year and a half ago and was a survey of the same kind of group that got together in this little girl's case in terms of trying to determine a neurologic prognosis and making clinical decision-making. This was in adult patients, not in children, based on a hypothetical case. This was done in Canada, which, as you know, is a single-payer system and has pretty uniform protocols and whatnot in terms of kind of how to deal with this. And so when they looked at what neurosurgeons, intensivists, and neurologists thought, based on this hypothetical case, not unlike this case we just talked about, you can see that it divided out about a third, and a third. So when you took it overall, about a third of the experts agreed with the prognosis in the case, about a third disagreed, and about a third were neutral. So that doesn't give you a lot of confidence. It didn't give me a lot of confidence that even the experts in the area really are good at predicting the outcome. And so in this particular girl's case, she, 4 weeks after her injury, she started to wake up from her coma. She began visually following her family. She started vocalizing. So 9 weeks after the injury, 9 weeks, she finally got some rehab. So they decided, okay, she's not going to die. We better get her some rehabilitation. So she started getting rehabilitation at 9 weeks after her injury. 6 months later, she was following simple commands. She was vocalizing and walking with assistance. And then a year after the injury, she was following 3-step commands. She had 25 to 30 words. She was sitting unsupported, and she was walking with support. So that's not a vegetative state a year later, not anywhere close to it. It's also not a normal state. So there was a lot of recovery that occurred. It vastly surpassed what any of the experts had predicted to the family would happen. But it's still, when you look at the outcome scales, that still comes out as a bad outcome because she was still totally reliant on others for her care, even though at that time she was still kind of toddler aged. When her mother came back, and she was a patient in Dallas, and we had this ability we followed all the patients out for at least a year. And so her grandmother, who was taking care of her primarily, views her as this miracle child, right? Because all of the experts said she's not going to survive, and if she does, she's going to be vegetative, and she's walking, and she's talking, and she's interacting, so this is a miracle. And so the question becomes was this a miracle or not, or could this have been predicted based on what we know about severe traumatic brain injury? So because of this database that we had started in Dallas, and because in Dallas there's a whole lot more traumatic brain injury than we see in New York, we had a lot of kids who had moderate and severe brain injuries that we're able to follow over a period of time. And so over a period of about 10 years, we had just over 300 children in this database. And these data were compiled by Julia Slovis, who's a third-year resident at Columbia, actually, she went back and looked at the Dallas database after we had closed it after 10 years. And this is a little bit of a busy graph, but I want to just point out a couple of things. One, kids who had either a GOS, this is the Glasgow Outcome Scale, or a GOSEP, that's the Glasgow Outcome Scale extended for pediatrics. They're pretty crude scales. They really just kind of dichotomize outcomes into good outcomes and bad outcomes with some granularity, but not much. But the point of this is that if you were discharged from the hospital like she was with a poor GOS, meaning you really weren't doing anything, if you looked over 6 months later, 50% of you still had a poor GOS, but 50% of you actually had a good GOS. So that dichotomous outcome had completely changed in 6 months. The GOSEP, which has a little more granularity in it, the results weren't quite as good. So 76% still had a poor outcome, 24% had a good outcome. If you look at the ones who were vegetative, so of these 300, 8 children left the hospital vegetative. The ones who, when you looked at them 6 to 12 months later, 7 of the 8 were no longer vegetative, and 2 of them had actually gone from vegetative to having a good outcome. That outcome I mentioned on the original little girl, that was a bad outcome. She still had a bad outcome. but 2 of them had crossed over into a good outcome. So I think this really just tells us, number one, that oftentimes these predictions aren't accurate, but at the same time, there is virtually always some kind of adverse sequelae to these severe brain injuries, and that these gross scales don't really get at all the problems these kids are ultimately going to have. When I finished my fellowship, I was really interested in studying mechanisms of acquired injury. So this kind of brain injury, which is a traumatic brain injury, is acquired. You don't think of it as having any genetic component. And my notion then, which 20 years ago, was that essentially everything we saw in the ICU, not everything, but the majority of it was due to acquired injuries and illnesses and things that didn't have underlying genetic dispositions. And so that was really what I wanted to study. So when we look at traumatic brain injury, no matter what the etiology is, there's some kind of common threads. It's common. It's extremely common. The causes are known, but they're really only partially preventable. They're still going to occur kind of no matter what we do from a preventative aspect. There's no treatment for these, but morbidity following these kinds of injuries is quite common. And our ability to predict long-term outcome is poor. If you don't learn anything else from this, hopefully you'll get that we're really not very good at predicting long-term outcome. There's a lot of marked recovery that occurs from all but the most severe and extremely uncommon brain injuries, and we don't really know the mechanisms underlying that recovery. Recurrent injury leads to worse outcomes, and one thing we can say about these injuries is there's always problems with memory. So there's problems with memory after all kinds of traumatic brain injury. So I'm going to switch gears a little bit, and for the next couple of minutes, I'm going to move from kind of human to animal modeling of this, because it's relevant to the case we just talked about, and it's really relevant, I think, to how we deal with this in the future. So since there's always problems with learning and memory, learning and memory really reside in the hippocampus. In humans, this is what the hippocampus looks like. So you got one on each side. It's very small. It looks like kind of an insignificant structure. It's not insignificant at all. If you don't have those, you completely lose your ability to form new memories. It's just gone. And then the hippocampus bilaterally integrates with a lot of higher function. In rodents, so this is what a mouse hippocampus looks like. You can see it's a much more prominent part of the brain in a rodent, and you can imagine why. Kind of the ability of a rodent to rely on spatial memory for survival is kind of paramount. So, rodents are constantly cruising through all sorts of things, and then all in food-seeking behavior, and then they need to get back home. And they've got a very prominent active hippocampus. That's what allows them to get back home. Genetically, they're identical, nearly identical, 99+% identical, and the wiring in the hippocampus between species is essentially identical. And so this is one of the reasons we wanted to study what goes on in the hippocampus after injury. So shortly after my fellowship ended, and I had been training in a developmental brain biology lab, I kind of focused on injury modeling for traumatic brain injury. And the model is I don't even know how relevant it is to human injury, but basically you can take a mouse and you can kind of take half the skull off and you do a little impact on them. And what you see is that this is kind of that same view I just showed you. And what you'll see is you get kind of a lot of mechanical damage in the cortex, but we became interested in the hippocampus for a couple of reasons. Number one, that orange staining you see is all for neurons. And you can see on the side that's not injured, there's lots of neurons. And on the side that is injured, there's a lot of green. The green is astrocytes, the orange is the neurons, and a lot of them are gone. So you get this big wave of neuronal death that happens after this injury. But if you look at the hippocampus, you see some cell loss here and some thinning, but this particular part of the hippocampus looks a little thicker and looks like it's not as injured as the rest of the brain. And it turns out when we first made this observation, this is at a time when people were starting to kind of investigate and accept this notion that you've got this population of neural stem cells in the brain. So that even in adult brains, and it's true in humans, it's true in all mammals, there's this reservoir of stem cells. And that reservoir is really found in two places. It's found in the dentate gyrus, where you see not as big an injury, and then it's also found here in the subventricular zone. And so doing what at the time were some fairly primitive experiments, we were able to show that it looks like the reason that was less injured was not because it didn't get injured, but because it actually got repopulated by new neurons. And that this green for astrocytes, most of those progenitor cells from here would become astrocytes and migrate and kind of envelop the injury. So that was important because it kind of gave us a focus and an idea about why some of this self-repair might be occurring. So what we decided to do, and I'm not going to go into the details of it, but we wanted to genetically model acquired disease, meaning at this time there was lots of activity being done in mouse genetics to, if you had a gene you were interested in, you would knock it out in a mouse and you'd see what kind of disease it caused. A lot of those genes they would do the same thing in humans. And it was a good model for studying certain genetic human diseases, not a good model for studying acquired diseases like traumatic brain injury, but that was kind of what we wanted to do. So we undertook this strategy to essentially genetically model traumatic brain injury by taking advantage of the fact that within the dentate gyrus, those stem cells express a particular protein called nestin. And so the regulatory elements of nestin had been worked out, so we could make mice that only express things within that stem cell population, and we could manipulate them genetically, just that stem cell population. So the first mouse we tried like this really just put a green fluorescent protein, so one of these fluorescent markers in that population. And you could see we could really get a good idea then of what the stem cell population looked like. And by using other markers, we could see what was really the stem cell versus what was a early neuron, which was a later neuron, and then ultimately a neuron. So you could really see the continuum of how these cells were kind of layered in that little microenvironment in the dentate gyrus. And that turned out to be important when we took these animals and did what we always wanted to do to them, was injure them. Because what happened with injury is this is what it looks like normally, and these kind of pink cells here are the astrocytes. And if you look after injury, I think everybody can see that those green cells, those stem cells get, for lack of a better word, they get activated. So they start dividing, there's a lot more of them, and they start migrating into areas where you don't see them in the uninjured state. And so this was a clue for us that maybe this activation of these neural stem cells was caused by the injury itself and was kind of a reparative, some kind of reparative reaction to what was going on. So we were able to ultimately show that you don't just activate stem cells, but if you genetically mark those cells and you look at them 3 months, 6 months later, the stem cells that were activated by the injury, they incorporate into the dentate gyrus as neurons, and they stay there for the rest of the animal's life. So the fact that you've got all these new neurons there, they must be doing something. So then we want to figure out what they might be doing, because as you can imagine, they can be doing really good things, like helping them recover from their memory deficits. It could also be doing bad things, like causing seizures or some other kind of aberrant connections. So really, we were able to show that you get these activation of stem cells and they stably incorporate as neurons, but is this good or not? And that was really kind of the next question we wanted to take on. So we use this same kind of genetic strategy. You can imagine that if you're activating these stem cells and you think they might be doing something, the easiest way to test that is just to get rid of them. So at the time of injury, if you could just ablate that response, then you could tell whether that was beneficial or not. So we developed a strategy to do this transgenically with a similar mouse modeling, but instead of just having a GFP there, we also had HSV-TK. Now, most of you in the room know how HSV-TK works, whether you know it or not, but it's the mechanism that ganciclovir and acyclovir work to fight herpes viruses. So this is the thymidine kinase from the herpes virus, and what happens with a herpes infection is if you give ganciclovir, this thymidine kinase phosphorylates ganciclovir, and it works as a thymidine analog and incorporates into the DNA and disrupts DNA synthesis and therefore kills the dividing cell. So any cell that has HSV-TK in it, if it's dividing and it's exposed to ganciclovir, is going to die. And that was the idea behind this, because we wanted to kill those progenitor cells. So when we made this mouse and we gave ganciclovir to the moms, to pregnant moms, this is a kind of a different view than I've been showing just to orient you. That's the tongue there, and that's the snout. This is the brain. And in mammals, brains develop kind of from a rostral to caudal way, so the hindbrain develops before the forebrain. This is what normal brain development looks like on a newborn mouse. In mice that were transgenic and moms were given ganciclovir, the hindbrain looks okay because it had already developed, but the forebrain is totally gone. And so we could just inducibly ablate all of those cells, either during development, or if you let the mice be born, they were totally fine, they were fertile, they did normal stuff, but you could give them ganciclovir as adults, and you could wipe out that stem cell population in the dentate gyrus. And so then you can imagine, once we figured out we could do that, then we could do the experiment we really wanted to do, which is injure the animals, give them ganciclovir, ablate that neurogenic response, and then look a month later to see how the animals perform in cognitive tasks. It takes about a month for those cells to mature and for those cells to participate in learning and memory. So what we did is we put them through a variety of behavior tests. Probably the best test, and this is the example I'm going to show, for this kind of spatial learning is Morris-Watermaze test. If any of you have worked with mice, you know what I'm talking about, but if you haven't, you can imagine if you take this pool of water and you make the water opaque and you put mice in it, they're going to want to get out because they don't like the water. And you put a little platform that's submerged, they can't see, but there's visual cues around the room. And so they kind of figure out where that platform is so they can get out of the water. And when you first do this, it takes them about 40 seconds or so to do it. And after a few days, they can do it in less than 20 seconds. They can do it in 10 to 15 seconds because they figure out where that little platform is. And that's a measure of learning because you do this every day. And what we found is that only in the mice that were injured and given ganciclovir and were transgenic for the TK, they didn't learn that as well. They still learned it. They went from 40 seconds to 20 seconds, but the other mice were doing it in kind of 10 to 15 seconds. And so it looked like it impaired their learning, although they were still able to learn. And then to test memory, what you do is you take that little platform away and you just put them in the pool and they swim around. And if they remembered where that platform is, they kind of hang out in the quadrant of the pool where the platform was. And so then when we looked at that, it was only the mice that were given the ganciclovir that were transgenic and injured. They couldn't remember anything. So they spent equal amounts of time in all parts of the quadrant rather than where the platform was. So this was a good indication and really kind of proved that this injury-induced neurogenesis was required for recovery of memory after traumatic brain injury, in albeit very artificial circumstances, right? We kind of dictate when the injury was done, when we test them, knowing kind of doing it at the best time that that we're most likely to see an effect. So you might ask, well, we know that that's a beneficial thing. Are there strategies to enhance neurogenesis after injury so you can kind of make it all better? And there are, but before you do that, you also want to mention at the beginning, there's some bad things that neurogenesis could be doing. And so we also wanted to look at those. And our strategy for that was to take the same mouse, and this was a collaboration with one of my colleagues at UT Southwestern. She studies neurogenesis in seizures. Well, it turns out that a seizure induces neurogenesis. And so the way you cause a seizure disorder in a mouse is you give them a seizure, you give them something excitotoxic, and then over a period of several weeks to months, they'll develop epilepsy. And so our idea was, could you take this mouse, could you ablate neurogenesis, and then give them a seizure and impair that seizure-induced neurogenesis, and then look months later and see whether they develop epilepsy or not. And it turned out that 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 turned out to be the case. So here it just shows that after a seizure in a wild type, you get all sorts of new neurons. And you get them not just in that subgranular zone, but you get them here in the hilus. If you give them the encyclovir, that didn't happen. So we were able to ablate that. And then, not only that, but if you look even a year later, in the animals that had neurogenesis ablated, they didn't have nearly as many seizures as the animals who had intact neurogenesis, and cognitively, they did much better. This is animals where you ablated the neurogenesis. So clearly in this paradigm, and you can see a lot of these hilar neurons in the group that had normal neurogenesis and that was also having a lot more both convulsive and non-convulsive seizures. So this really has some implications for, when I trained, we would tell parents when their child had a febrile seizure that, don't worry, this doesn't mean they're going to have a seizure disorder. Hopefully everybody knows that's actually not the case. So we know that at least 5% of children who have febrile seizures will develop epilepsy. That is not unlike in this model where we know the seizure itself will cause aberrant neurogenesis. Might that be contributing to the development of epilepsy? We don't know. And it probably, and I'll allude to this really at the end of the talk, about underlying genetic factors that may kind of help make that determination. So I think as we try to answer this question, it's become more complicated because is injury-induced neurogenesis beneficial? It certainly looks to be beneficial in some aspects of recovering learning and memory after a brain injury, but at the same time, it may also be contributing to the development of seizure disorder, something that's a pretty common sequelae of traumatic brain injury. And so it becomes more complicated. So kind of the next question we wanted to get at is whether there were underlying genetic factors that influence this. And so the way we did this, and this was done by Jennifer Gilley, who was a graduate student in the lab, if you look at those GFP expressing cells I showed you, and you look at an early time point at P7, there's lots of these cells. And if you look when the animal's a month old, there are a lot fewer. So why do you have a lot of them and then you go to very few? You would think that there might be some genetic factors that kind of regulate that process. So what we did is, because these are fluorescent, you can stick them through a flow cytometer and just separate them. And you can separate them and just kind of look at genetic expression profiles. And one of the genes that came out as being very highly expressed here, but not expressed much at all there, was ApoE. Now, we were interested in ApoE, and a lot of you may have heard of ApoE because in mice, there's only one form of ApoE. In humans, there's three forms, ApoE2, E3, and E4. And these are really commonly occurring isoforms in humans. So about a quarter of us had at least one allele for ApoE4. And because of that, our risk of developing late onset Alzheimer's disease is much increased. So with all the genetic work that's been done in neurodegenerative diseases like Alzheimer's disease, the most predictive of developing it is whether you have one ApoE4 allele or not. If you have two, it's even worse. And it's 25% of the population who has at least one. ApoE3, on the other hand, seems to be more the wild type one. And then ApoE2 probably has some advantages in developing Alzheimer's disease, but some disadvantages in some cardiovascular diseases. It's a little unclear what it's doing. But the fact that they're as common as they are and they can influence disease is interesting. Because of the association of ApoE4 and Alzheimer's disease, it's also been looked at in traumatic brain injury, because if you have a traumatic brain injury early, your chances of developing Alzheimer's-like dementia later on are quite increased. And it turns out that if you have one allele for ApoE4, your risk of death or severe disability increases if you take the same kind of traumatic brain injury. So it seems to be a predictor for a worse outcome after traumatic brain injury, as well as for Alzheimer's disease. So those are the reasons we were interested in it. So we wanted to take a look and see what the expression of ApoE looks like. We found that it was expressed in both astrocytes and progenitors, it was very well known to be expressed in astrocytes. It wasn't known to be expressed in progenitors. And when we look at P7, we couldn't see it at all. And if you look at P28, you see really abundant ApoE expression within that progenitor population. And when we looked at animals that were deficient for ApoE and that we then crossed to our GFP animal, and you looked over time, if there was no ApoE, it wasn't significant until you got to animals that were really several months old, and at 9 months old, they had hardly any of these stem cells left at all within the dentate gyrus. And then, of course, because we injured things, we wanted to see what it looks like when you've got those animals that don't have ApoE, have GFP, and when they get injured. And what happens is what you might predict is that the expression of ApoE goes down in that progenitor population as proliferation goes up. We could show this within the whole hippocampus using Westerns, and it only goes up down by about 1/4, but it was a significant change. And then when we injured those animals, both the ApoE deficient and the wild type ones, in the ApoE deficient animals, you got lots of cell proliferation, but not in the progenitor cells. So if you don't need to pay attention to the rest of this graph, but down right here in the ApoE knockout animals, you really got attenuation of this robust response. So there's a lot of other stuff I can tell you about ApoE and how we model this in mice, but I kind of want to bring it back to human studies now. And as I mentioned at the beginning of the talk, kind of what's changed this is kind of what we've been doing over the last 20 years, is trying to figure out the relevance and the mechanisms of this injury-induced neurogenesis. To give you some background on what's been going on clinically and kind of where I think this field needs to be moving, I want to show a few examples. So 20 years ago, when I mentioned I was a fellow, the traumatic brain injury guidelines were first published. So this was an effort by a group of neurosurgeons and others to really kind of see what works and doesn't work in traumatic brain injury. And the conclusion of those first guidelines, so those first guidelines were published really exactly 20 years ago. They were published in 1996. And the conclusion was there's very little evidence that anything we do in taking care of a child or an adult with traumatic brain injury helps. But what they suggested is we need to do a lot more randomized trials, right? And that's kind of always the answer, is you need to do more trials. So I wanted to share this with you without going through all of the trials that have been done in traumatic brain injury. But this was published less than a year ago, and it was really a state of the science overview of randomized controlled trials. So this was a 20-year initiative of doing randomized controlled trials, evaluating the acute management of moderate to severe traumatic brain injury. So a lot of these trials have been done. So they found 191 completed trials that enrolled 35,000 patients. So 35,000 patients with moderate to severe TBI were enrolled in a randomized trial. And the conclusions of this review that was just recently published was that considerable investment of resources in producing 191 completed RCTs for acute TBI management has resulted in very little translatable evidence. So I can tell you the way we manage TBI now and the way we managed it 20 years ago is very similar. And it's a consequence largely of just kind of not understanding in such a heterogeneous injury what's going on. And so the advances we've seen, I believe, have really been more due to more protocolized care, so people are doing more consistent care, but our actual interventions haven't really changed much at all, and there's really no evidence for them. So you might say, okay, that's TBI, and TBI is dirty because it's, a lot of mechanisms that cause it. There's age that's going to play a role. There's it's just a messy disease. It's one of the reasons very few people until recently have started studying TBI, because it's a messy disease. So now I want to move from TBI in particular more to pediatrics and pediatric critical care in particular. So 20 years ago, pediatric critical care was kind of in the same position as TBI. There was a lot of movement towards going away from like the case reports and the small case series to doing randomized controlled trials. But there was a recognition that in critical care, to get the number of patients you need to do meaningful trials, you need to do multi-center trials, right? So you can't just take one institution's experience, you got to get multiple institutions. The Canadian Critical Trials Group was having some success with this because, again, it's Canada and you got a single system and it's much easier to do that. About 20 years ago, there was an initiative to do this in pediatric critical care. And so this was published also less than a year ago to see how we've done. So what happened is we've got this very well-organized, very well-funded, great consortium of critical care investigators, specifically for pediatrics, that's trying to answer this question. And they published kind of the overview of 20 years experience of these trials. And the conclusion was that for the research network trials, early stopping occurred in about 50% of network randomized controlled trials and 27% of non-network trials, most commonly for futility. None of the network, but 45% of the non-network trials found a significant difference in their primary outcome. So none of the network trials have found a difference. I can tell you since this has been published, there's been 2 more major network trials in pediatric critical care that have been published in the New England Journal in the last 4 or 5 months. One called the Half Pint Trial looking at tight glycemic control, another one looking at hypothermia after out-of-hospital cardiac arrest. Both of those trials were stopped early because there was no benefit to doing them. So despite this huge effort at doing these very complicated trials, a lot of people involved, a lot of money, a lot of resources, almost all the trials have been stopped early because of futility. So we're not doing a good job of kind of figuring out the best way to put together these kind of trials to get the kind of evidence we need to really kind of push the field forward in terms of how we take care of critically ill children, how we take care of children with bad brain injuries. Okay, so what do we do about that? Now I'm just going to talk about a very small example of what we've been doing in our ICU and our institutions, just, I guess, give you a flavor of what I think we need to be doing if we want to see more efficacious trials going forward. So one of the things I was interested in, it's probably not much different here, is that when you admit a patient to the hospital, whether they're in the ICU or in the hospital, and something is not right about the patient, and you oftentimes can't put your finger on it, you call a genetics consult. And sometimes the geneticist will say, you know what, this doesn't quite fit anything, but I agree with you. It looks a little goofy, and we're going to send off some sequencing studies. We do the exact same thing. We seem to, I just had this notion that we were getting probably kind of a higher hit rate from these genetic studies than I would have predicted, particularly when they didn't really fit any pattern. So along with Wendy Chung, who's one of our geneticists, she and I kind of reviewed it, just a 12-month period that was from July of 2015 to the end of June 2016, where we had 24 cases, which is about 1% of admissions. So we have about 2,300 admissions. It's about 1% of admissions where we did whole exome sequencing. So kind of the usual genetic workup and everything wasn't fruitful, but the geneticists agreed that there was probably something more. So they sent it for full sequencing. We found that 10 of the 24 were negative, so we didn't get a result out of those. There was a variant of unknown significance. These we don't really know what to do with because there's a variant that could be pathologic, but either the gene hasn't been described or nobody knows exactly what that gene does and whether it could account for the child's disease. That was found pretty commonly in 6. And then we had 7 of 24, so 30% had a mutation that explained the phenotype. And so that's a hit rate of 30% on a test that is a definitive test. And so my view is that's a pretty high hit rate. And probably a test you're not using as often as you should. One of the interesting things we found is that when we looked at those 7 patients, 6, it turned out to be 6 of 9, so 2/3 of the patient with a primary neurologic diagnosis had a mutation that explained their phenotype. And the other interesting piece of that was that the average time to diagnosis was 82 days, so almost 3 months to get that diagnosis. And the average PICU length of stay, so not even the hospital length of stay, but the time in the unit was about 3 months. So I kind of thought those two were probably related. And so it brings up a couple of questions. So certainly 20 years ago, when there was genetic testing that you could be done, there were certain chromosomal arrays you could do or fish studies, and you could get some diagnoses that were helpful in the sense that it kind of gave you a diagnosis. But really what we're mostly interested in, and certainly what parents are interested in, is can you intervene? Is this kind of something you can interrogate and actually do something about? And so I want to tell you two very brief stories of two of the patients from this 6 of 9. Both families, I had the privilege of taking care of both of these kids through significant parts of their stays. Both families want their stories told, and we're very happy to kind of let me share what happened to these families. And I think they give an example of kind of how a lot of these things need to be handled going forward, both good and bad. So the first patient was Ahmed. He was a darling little guy. He was 7-month-old from the UAE. So he had a 2-month history of seizures and losing developmental milestones. So I think everybody in this room knows if you have a 7-month-old who starts seizing and losing milestones, that's a bad thing. They couldn't get a diagnosis in the UAE, so the family came. So mom and dad brought him, left the 2 toddler siblings back in Abu Dhabi with the grandparents, and they moved. Essentially, dad went back to work, mom moved into the ICU, and she lived there. And her plan was to stay until we figured out what was wrong with her child. He had a rough course. He was on a lot of anticonvulsants. He had respiratory insufficiency, which is why he was in the ICU. He was kind of constantly on respiratory support or not. Never looked very good. He was minimally responsive. He had an MRI that was suggestive of mitochondrial disease, and had a whole bunch of consults. He had neurology, metabolics, GI, kind of all the things you would expect in a complicated patient like this. He had a muscle biopsy. It showed mitochondrial depletion with presumed underlying genetic cause. So then he ultimately got, not that long, within 10 days of admission, he got his whole exome sequencing sent 10 days after he'd been here. He was in the PICU for his entire stay with hard to control seizures, feeding intolerance, respiratory failure, insufficiency, and overall decline. Ultimately, he got 5 months after he was admitted a definitive diagnosis, and he had an autosomal recessive mutation in this mitochondrial gene that caused his disease. And it took a long time. This had never been described before. This is a new disease, but there was something known about the gene function, which had actually only been described about a year earlier. As soon as they got the diagnosis, the parents asked if they could go home. And Ahmed was too unstable to get him back to the UAE, so he died a week later, just after his first birthday. Spent almost 6 months in the unit while the family's kids were growing up, kind of across the world, and they left home and were devastated by this. So it brings up the question of how could we have done better in terms of getting at that diagnosis, but it also tells you that getting that diagnosis earlier, what it would have facilitated was getting him home, which was a big deal, but it really didn't get at any part of the underlying disease. The second case was similar in many ways. So this is Laurie. Laurie was, again, an 11-month-old. She was referred for possible metabolic disease. She also had a 2-month history of losing motor milestones. She was a local child who was in a different hospital than ours. She had some hypoventilation and apnea that required her to be intubated. She had an MRI. She had a lactate peak. She had some brainstem changes. It was all consistent with this picture of Lee's disease. And she had a metabolic workup that included whole exome sequencing. Hers was sent a day after admission, and it was sent on a very quick platform where you could get much quicker turnaround. And she actually got the results in 21 days. And what she had was a homozygous mutation in this mitochondrial complex 1 gene that was known to cause Lee's disease. So her diagnosis came 3 weeks after she was admitted, and it was a very hard diagnosis because it was known that this mutation causes Lee's disease. Lee's disease is a bad disease. So what happens in children with this disease is they just continue to have neurodegeneration, and they become ventilator dependent. They oftentimes develop seizures, and they die at a very young age. And that's kind of that's the natural history of this disease with this mutation. And so I counseled the patients along with the neurologist and the metabolic specialist, Daryl Vivo, about do you want to do we want to do a tracheostomy, do chronic ventilation, send her to kind of a nursing home facility? What do you want to do? Family was very adamant about wanting to try anything that was possible. Typically, these kids get some vitamin supplements and they get sent home, and then they expire within a few months or a year or so. So Daryl DeVivo, who's the metabolic specialist, the day after we made the diagnosis, he comes to me and he said, okay, he shows me 2 science papers. One had just come out like literally that week. And this was hypoxia as a therapy for mitochondrial disease. The second paper was mTOR inhibition alleviates mitochondrial disease in a mouse model of Lee syndrome. So this mouse model of Lee syndrome was the exact same mutation that Laurie has. And what these investigators had found was that there was overactivation of the mTOR system through unknown mechanisms. They didn't know the mechanism, but they knew there was overactivation because a downstream marker, phosphorylation of this protein called S6, was quite increased. And so in the mice, they inhibited that and saw that the disease did not progress. Hypoxia essentially did the same thing. We had worked in the same area, and so talked with Daryl about this, is what hypoxia does to the developing dentate gyrus that I was telling you about, is it actually impairs brain development in the way hypoxia might. And we had shown that it does it through the mTOR pathway. So putting all of this together, it looked like, the possibility of disease modifying in this girl was really either raise her in hypoxia, which Daryl brought up to me because he's a neurologist, and he's like, I don't think that's very practical. And I said, yeah, it's not really very practical. He's asked me, can we turn it down on the bed? I was like, not really. But we could do mTOR inhibition, was something we could do. And so after kind of extensive counseling with the family saying, we're going to do an experiment on your child. It's only been done in mice. We have no idea what it's going to do. What we do know it's going to do is in a normal child, it's going to impair their cognitive development. That we can tell you for sure. We don't know if it's going to do anything with your disease, but we got nothing else to offer. The parents said, yeah, let's do that, just because we had nothing else. And this is a picture of Laurie from about 2 or 3 months ago. This is a year after we started the therapy. You can see Laurie, she still has her trach. You can see it, but she doesn't need a trach because she's not on the ventilator anymore, and we can probably just take it out. She's 26 months old. She walks with assistance. She's got several words that she talks around her trach, which is kind of a tricky deal. She doesn't need chronic ventilation. She doesn't have any seizures, and she's gaining milestones. We haven't cured Laurie of her disease. I think we've modified her disease using a lot of stuff that we learned in mice and other people have learned in mice on this very rare disease. But it's not a cure, and I have no idea what's going to happen to Laurie, and neither does her family. But I can tell you nobody's going to stop the mTOR inhibitor. And so what do we learn from this? So really it's how kind of going forward can we do better, and going back to all these failed critical care trials and failed TBI trials, really incorporating existing technology now and doing it more rapidly in the most critically ill children. So the rapid sequencing technology to more patients for diagnosis that I think will influence both genetic and non-genetic diseases, for management, not just management of the underlying disease, but also the pharmacogenetics you get, whether they clot normally or not, you need surgery and things like that. Ultimately, directing clinical trials that might work, rather than doing these very large trials and taking all comers who don't have a really well diagnosed disease. Things like in the ICU, I can tell you ARDS. So what does ARDS mean? It means you got bad lung disease and your x-ray is abnormal. That's all it means. And we throw them all into the same trial with the same therapy, regardless of the underlying etiologies of why they develop that. And that doesn't work. We can't do that anymore. We have one really good example, recent example. Nusinersen is it's an antisense oligonucleotide therapy for SMA, for spinal muscular atrophy, that works. And this trial just got halted early, just like all these other trials, but it got halted early because it works. So you take little babies with SMA and you give them this drug and they're not needing chronic ventilation. And it's doing amazing things, but it's based on the underlying biology that was all done in mice. The preclinical stuff was all done in mice, and now we're doing that in humans, but it's really informed on the basic science. And so ultimately this is going to help us drive research, innovation, and education as we're able to more kind of really precisely define what our children who are in our ICUs and everywhere else who are sick have. So anyway, I'm done. Thank you very much for the invitation. I think I've got a couple minutes for questions. So, one in back.
Beneficial to start this therapy for an age child. Can you start this on a 8-year-old kid and feel some benefit?
So don't know the answer to that. My view of it is the earlier the better. And so one of my it's a frustration. I mean, the technology all exists, right? So when we talk about sequencing, and I don't know what your sequencing experience is, but the technology exists to get that result back in 7 days. But the typical course is a couple of months. The more severe the disease, the less time you have. So my bias is that we need to be doing it quickly, we need to be recognizing quickly, and we need to be doing it quickly. Based on these cases, I've been able to convince our hospital to send the next 10 kids we see, like Laurie or like Ahmed, meaning they have a primary neurologic disorder that is undiagnosed and we think might be genetic. The hospital has given us permission to do 7-day sequencing on those children, and the hospital is just going to eat the cost. The hospital isn't doing that because they're just nice and that's the right thing to do, right? I had to explain to them that I think our length of stay will decrease by a month for every child that we can do that for. And that extra $5,000 that it costs the hospital will be offset by the $60,000 they're going to save by getting that patient out of there sooner. And so I think it's that kind of, I think we have to cut those kinds of deals to make the hospital realize it's in their best interest. We're not just doing this for, for kind of cool mental exercise. And we're not just doing it for the families. In the case of Ahmed, we got nothing for that kid. We probably will at some point, but what we did have was the ability of, we could have gotten him out of our ICU and back home much, much sooner.
You spoke about the review of all these different trials around the country. Was that, I don't know how much of that was pediatrics versus adult? I was kind of assuming a lot of that was in adult, I think we have said so, but is there a difference in outcomes and even in the pathobiology in kids versus adults?
Not enough has been done in TBI. So the traumatic brain injury studies I showed you were really, those were all adult trials. The best, far and away, the best pediatric TBI trials have been done by Dave Allison. And you guys probably know that. But the major trial he did that he was in the midst of when they came here, the Cool Kids trial, ultimately didn't finish because of lack of efficacy and difficulty enrollment with changing demographics and trauma. The other trials I showed, those were all pediatric trials, though, all pediatric critical care trials. So they're pediatric critical care is probably one of the biggest offenders of lumping things together. I use the example of ARDS. It's not type 1 diabetes, right? It's just kind of this description of a bad disease, but we don't really know what goes on. Anything else? Okay, thank you very much.